Hello everyone. My name is Mahmoud Salama. I'm an assistant professor of obstetrics and gynecology and the director of the Oncofertility Consortium at Michigan State University in the United States. Thank you so much for joining our Oncofertility webinar today. The webinar will take about 45 minutes, followed by 15-minute questions and answers. Please keep your mic muted and your camera turned off throughout the webinar to avoid background noise and to ensure a smooth webinar broadcast. If you have a question, please post it in the chat. We will open the discussion at the end of the webinar with the ability to turn on your mic and camera to ask questions. This webinar will be recorded and uploaded afterwards to our Oncofertility Consortium YouTube channel. So thank you so much for your continued support and partnership. And today we warmly welcome Dr. Maria Bourlon, Associate Professor of Medical Oncology from Mexico, and Dr. Mohamed Khrouf, Associate Professor of Obstetrics and Gynecology from Tunisia. Thanks a lot, Maria and Mohamed, for joining us today, and we are looking very much forward to your talk on oncofertility practice in limited resource settings, experience from Latin America and Africa. Maria, please.
Hello, I would like to thank Dr. Salama and the Oncofertility Consortium today for inviting me as a speaker for oncofertility practice in limited resource settings with a particular focus on Latin America and Mexico. That's where I practice. I'm a medical oncologist focusing on GU malignancies, and we've struggled for years with patients wanting to preserve fertility, and we know about the challenges and barriers we have in this area of the world. As for the agenda, I would like to talk a little bit about LATAM and Mexico, try to give a context of how many countries we have in LATAM and how heterogeneous they are. We will talk about oncofertility in developing countries, including some from Latin America. Also, an emphasis in Mexico, that's where I practice, and some future perspectives about how to handle the problems and barriers that we have. First of all, we need to understand that LATAM is a very big and heterogeneous region. Latin America and the Caribbean accounts for 17 countries, and a region with a lot of contrast, which includes different cultures, different racial differences, different religions, different language, different income, and different government. So talking about Latin America is talking about several different nations. It is an extensive region from the Bahamas and Mexico to the very south, Argentina and Chile. And there's over 670 million people as of 2016, and it's expected to increase over the years. We also know that the World Bank income country classification by income level is very diverse in Latin America. Here you can see highlighted that we have few countries in this region from high income level. Most of them will be from upper middle income and lower middle income, and we will still struggle with low income areas and even areas that are not really classified. So this really makes it a challenge to analyze what happens with healthcare, particularly oncofertility in this huge area. I think it's important to notice that there's a significant number of cases in both sexes, and we need to know that prostate, breast, colorectal cancer, and lung cancer remain as the most common causes of neoplasms. Also, it is important to explain that the estimated age standardized indices rate for both sexes from 0 to 44 years old, which is really the population we're most concerned about oncofertility, includes initially breast, cervix cancer, thyroid tested, some blood malignancies such as leukemia and lymphoma, and ovarian cancer. So really, these are going to be the types of cancer we're most concerned about, and the consultations we'll see the most. It is important to know that assisted reproductive technology regulations in Latin America vary a lot. Most Latin American countries do not have regulation that specifically control assisted reproductive techniques. Here you can see Mexico, Argentina, Uruguay, Colombia, and other countries. Please note that many don't have available a legislation or regulation available. Some of them may have a law, which is really recently from 2013 to date. And this really needs to be addressed because there's not only economic inequity, there's not only the influence of certain religions as Catholicism, but also there is a need to establish regulations that can homogenize the conduct that we follow in public and private services regarding assisted reproductive techniques in several countries. So a little bit of more focus to where our practice, which is Mexico, which is part of Latin America, one of the biggest countries in this area. We are an upper middle income country. There's high inequity held regarding international poverty line and national poverty line. Our healthcare system has insured around 80% of the population, but 20% remains uninsured. And private insurance is really scarce. And, less than 5% will be covered, and oncofertility expenditures are not covered by insurances. So usually every single cost regarding oncofertility comes out of the patient pocket. Let's do a contrast about Mexico's population regarding those that are very young compared to those from the US. And let's look at the percentage of the population of less than 45 years in the United States. It's expected to be around 58%, but it's expected to be 72% in Mexico. So really this contrast that we have a young population and the need of oncofertility might be higher. In Mexico, we have several cancers reported in 2020. 20% were in women or men less than 44 years old, and most of them are highly curable malignancies. Unfortunately, we do not have an established cancer registry, so most of our plans come from indirect estimates from neighboring areas about what are the types of cancers that will affect both sexes in young ages. As you can see, it is expected that we're going to see a lot of patients with breast, thyroid, leukemia, cervix, testis cancer, colorectal cancer, and some others such as non-Hodgkin lymphoma, ovarian, and central nervous system malignancies. So this is really what we expect to see in terms of frequency. And what do we know regarding oncofertility in Latin America as developing countries? I really need to address that this is going to be mixed data. A lot of this work has been done by Dr. Salama in an effort from the Oncofertility Consortium and the Open Network. And we really see that Open, which is the Oncofertility Professional Engagement Network, is an interdisciplinary collaboration on more than 45 countries. And we really try to coordinate efforts to overcome unmet needs in this field. So you can see that we have Open members in Mexico and several areas in Latin America, such as Brazil, Argentina, Peru, and other areas. And what we were able to see in this collaboration in which oncofertility scores and options in developing countries were assessed, look that we had African countries, and I'm sure Dr. Mahmoud will talk a little bit more about the African experience, but we also have several countries in these low to middle income countries participating from Latin America, which included not only Mexico, but Brazil, Peru, Panama, Colombia, Guatemala, Argentina, and Chile. Actually, the oncofertility score that comes out from the actual points of utilization that oncofertility might have versus the maximal points of utilization were reported for all these regions, and we have a representation from Latin America. And here we can see the oncofertility scores and options in these developing countries, including Latin America, for childhood cancer. And let's take a look that ovarian tissue and testicular tissue freezing remains low. And still, when we talk about shielding in the case of radiation, fractionated radiation, or phoropexy, which are available techniques in poor areas of the world, remain in a low rate of use. So this is very interesting for children, but it also remains very interesting for breast cancer. We know breast cancer is the most common malignancy young women are going to face. And it's important to see that still there's underutilization of egg freezing and also of GnRH analogs, even that we know they can protect ovarian function all over the following years in women. They not only help us protect fertility preservation, but hormonal production. And then finally, blood cancers, which we know leukemia and lymphoma have a significant incidence. There's still a low utilization of these strategies, particularly in these areas of the world. So now let's take a look from that previous analysis to a new analysis in 14 oncofertility centers with low resource settings. And really here we know centers with limited resources and settings with optimum strategies. There is a difference that really those that are in limited resource settings might have less usage of preservation options before cancer treatment, preservation options during cancer treatment, and also restoration options after cancer treatment defer. So we really know that we need to do an effort across all the disease spectrum, but we know the most efficient will be before cancer treatment. So in terms of barriers and opportunities, we know that this online survey in which 9 developing countries participated, we have 5 countries from Latin America participating in these barriers and opportunities questionnaire. And there were 6 categories. We wanted to know a little bit about the country, about the cancer care, fertility treatment, barriers, and opportunities. And we really knew that many fertility preservations were available, but not overall available to all the population, but for those that can pay. There's a third-party reproduction unregulated, mainly, and prohibited in many areas. We know that fertility services in private settings are not covered by insurances and that costs may vary widely. And we know that there's some barriers because we may have conservative religious ideas, some cultural misinterpretations, and ethical attitudes that might not be open to implement assisted reproductive techniques early in time for our patients. So chances to overcome the barriers, do we have a chance that the barriers can be overcome? We think there's hope because most physicians think that the medical, economic, social, and legal barriers in Latin American countries can be overcome in contrast to some African countries. So really let's hope that we actually know that there's obstacles, but there's a way to work on them. It's important to know that this online survey about countries regarding oncofertility practice also was follow-up and repeated, and we know that there's an opportunity for expansion, growth, and development. And our current goal is to ensure that conversations take place, that providers are empowered and can navigate their patients. And finally, we know that the barrier of lack of awareness among healthcare providers and lack of funds can also be overcome over time. Let's see a little bit about how can we deal with this, and we can see that there's different perspective between African countries and really Latin American countries in which the chance to overcome barrier seems higher in our cultural context in Latin America than maybe the African context. And finally, I wanted to speak a little bit about, the fact we know that Latin America may have a high incidence, for example, of penile cancer, prostate cancer, and we know very little about the oncofertility and fertility preservation that's being dealt in social media. And this is a study we conducted in Twitter to see whether oncofertility and fertility preservation was a conversation among different countries. And we know that most tweets, if you can see, come from high-income countries. So it's kind of worrisome to see that even in low-income countries, we have less engagement in social media. This can be explained maybe because high-income personnel is more used to work in social media in high-income countries than in low to middle-income countries because access to internet is lower. But it's really impactful to see that we have a high need to implement oncofertility strategies in low to middle-income countries, and still the conversation, particularly in Latin America, is low, and in Africa is really scarce. And we know that mainly the conversation is about medical papers and information for patients, but we really need to do more networking regarding this conversation in social media. And I think it is a call into action of what we need. Finally, I want to explain a little bit of the research we've done regarding oncofertility in Mexico. And we really wanted to characterize what's happening regarding these fields. We had some fertility concerns addressed among breast cancer patients. This was a multi-center study. It was cross-sectional, and it was mainly emphasizing to address those women with less than 40 years old. The median age was 34 years old, 55% were partnered, 35% had no children, and 48% were willing to have children prior to the breast cancer diagnosis. So really impactful information that most of our women are willing to still have maternity wishes. 44% of our women had a fertility concern, 22% changed treatment due to fertility concern, and only 3% were able to afford fertility preservation extra expenses, just because I've explained that these come not covered by insurance, but come from out of pocket from patients' income. About information about infertility risk, let's take a look about developed countries, which is higher. And in Mexico, fewer patients report having information. And information regarding cryopreservation is actually really, really low, 1/10 of that reported in developed countries. Regarding patients undergoing bone marrow transplant, it's really important to address them because we know leukemia and lymphoma are one of the most common malignancies young Latin American people are going to face. This is a single retrospective study about the gonadal dysfunction prevalence before and after treatment in those patients undergoing bone marrow before 45 years old. And we know that the most common diagnoses were leukemia, lymphoma, testicular cancer, and some other hematologic malignancies. So let's take a look to the pre-bone marrow transplant assessment and the post-bone marrow transplant assessment. We know that gonadal dysfunction was 16% in male, and after treatment, 20%. But let's take a look on the pink, and we know that gonadal dysfunction was 19% in women, and after treatment, it was 81%. So I really think it mimics what we've seen in other areas of the world. And we need to know that post-bone marrow treatment gonadal dysfunction is higher in females and higher in male ablative conditioning. So we really need to make an effort, and it seems that it needs to be higher when we're talking about females because the challenges might be higher, the cost might be higher, and access to fertility preservation might be more difficult in this population. Also, we not only address, breast cancer, hematologic malignancies, but we wanted to see one of the barriers that was reported on the Salama study about the knowledge of oncofertility about primary care providers. This was a single institution retrospective study of internal medicine providers. We know that the median age was 27 years old during fellowship, and residents providing care for patients under treatment of detrimental fertility were as follow. You know, we know that most of them had seen fertility hazard treatments. So we really were seeing a population of primary care physicians involved in patient care. We know that few of them could report more than one method for fertility preservation in men. And you can see that most of them could only mention one or zero methods regarding fertility preservation in women. And these are the primary care providers. It's also important to note that there was a self-perceived confidence for providing fertility concealing in 10%. So we really are concerned that only 10% felt comfortable talking about oncofertility with their patients. Is this different in the primary care setting than in the oncologic setting? So this was oncology-related physician. This was done at the Mexican Oncology meeting that's held every year. It was a survey, and we could see attitudes and knowledge regarding fertility preservation for breast cancer. 83% had a high rate of responsibility and really thought it was important for them as physicians to conceal their patients. And it was mainly surgical specialists, and their attitudes were different regarding informing, discussing, and referring patients to reproductive specialists. Interesting in this analysis, you know, responsibility was key because those who felt a high sense of responsibility were more likely to inform about risk, about fertility preservation options, to refer their patients, and to perform effective concealing. And it's also very interesting that there's an age matter. Those under 40 are more likely to inform and provide concealing. The feasibility of testicular cancer was also assessed for testicular preservation. This is a group of patients seen in the last 10 years, and 30% completed, an assessment, and 20% underwent fertility preservation with cryopreservation. So I think we could inform it's feasible, and this is really important in terms of moving forward this field in a low-income nation. I just wanted to share with you that our breaking news is we're currently doing testicular and ovarian tissue cryopreservation at the National Institute of Pediatrics. So this really expands the options for our children in terms of oncofertility care. And where do we think this is going to go, and what are the conclusions at this point? I really think we need to improve care in Latin America. I think there's key data we need to keep in mind. Our open strategic goals is to improve access, advance research, educate, and collaborate. And for that, I really think we need to develop registries in Latin America who are lacking. We need culturally appropriate resources in terms of religion, idiosyncrasy. We still have a huge population of native Indians, scholarships, and public funding. For example, Argentina has full funding for assisted reproductive techniques. And I also really think we need resource stratified guidelines. If we see a low-income setting, maybe our patient doesn't have all the options, but at least they should be concerned about unconcealed about adoption, surgical sparing oncofertility techniques such as transposition, avoid radiation, fertility sparing surgery. And if we get a little bit of funding, then LHRH analogous, banking, and finally, if we're in a high-income country or high-income setting, in a low-resource setting, do uterine transplant and tissue banking as we're currently doing for children at the National Institute of Pediatrics. So I really need to see one step at a time. Adult care comes first, local referrals come first, but then we need to make a focus on adolescents and young adults, care plans, psychological support, and finally, pediatric oncofertility care, a good frame to develop research and really advance the field once at a time. I really think that my final message is Latin America is an heterogeneous region with several countries with different challenges. And particularly, oncofertility is not deception, with many economic, social, and cultural barriers. Really, few patients in Latin America receive appropriate uncofertility counseling because of clinicians' lack of time, knowledge, and referral patterns. And we need to develop programs that increase fertility preservation awareness and access. National and international collaboration, I believe, is key to be able to reach this. And with this, I will finalize this talk about the perspectives we have in Mexico and Latin America. And I would like to thank again for the opportunity to give this talk. And we will now go to the African and Tunisia experience. Thank you very much.
Thank you so much, Maria, for this great talk. So, Mohammed, can you start sharing your slides?
Yes, thank you, Mahmoud.
You are welcome.
Thank you, Maria, for your talk. I learned a lot, and I really enjoyed your conclusion and the framework. Your proposal was great. Let me now talk about the oncofertility in Africa. So I'm Dr. Mohamed Khrouf. I'm working in Tunis. Tunis is the capital of Tunisia, and Tunisia is on the top of the north of Africa. And I have worked in the public hospital of Aziz Othman, and now I'm working in Fertilia Center, and both of our centers are involved in fertility preservation and oncofertility. As all you know, the cancer is not sparing Africa, and the prevalence, even if it's lower as reported in this graph, we know that maybe we have quite the same prevalence of cancer. But the difference is about the survival. Unfortunately, in Africa, we have a lower survival rate compared to the other part of the world, probably because of the resources, the medical resources, and the financial resources. So one question is always in our mind: is oncofertility in this context a priority in Africa? In this publication, the author said that the topic of fertility protection can only be of importance if sufficient oncological care is guaranteed. But on the other side, we have international guidelines, and the international guidelines may apply to different parts of the world. So do you think that oncofertility is like icing on the cake, or an essential ingredient of the cancer care? We believe that is a standard of care, and we have to learn to how implement the oncological care with the inclusion of the oncofertility. Why? Why? Because we have to check from the patient side. In Africa, if you are a woman and you have a breast cancer, you will have to survive to the disease. Maybe you will in some countries you will face some difficulty to have your health care, and you have to also accept what we call the mutilation due to the surgery, but also the visible chemo side effects. But if we can relieve you from the burden of infertility that may add stigma to a stigma, it will be really something that we can add to our patient. And this is why we believe that it should be a standard of care. And it is possible because assisted reproductive techniques are available in Africa. Sure, we have less number of procedures per million people reported in Africa, as it is reported in another report in 2019. But the offer is spreading, and we have many, and the majority of the countries reporting having an RT activity and also a freezing activity. So freezing is mastered by almost all the IVF centers in Africa. And there is also an interest in fertility preservation, because we have more and more countries attending to the conference of oncofertility. So we have reached this degree of maturity of people who are practicing RT and looking to offer oncofertility to their patient. More countries in Africa are reporting having oncofertility activity already, as we are going to see. In these two publications by Dr. Mahmoud Salama, we see that there is some successful experience in Egypt, in Tunisia, in Nigeria, and also in South Africa. So some experience are already existing in Africa. Like the Tunisian experience, for example, the Tunisian experience started in the hospital, in Aziza Othmana Hospital. It's the teaching hospital of Tunis in 2015. And now the public hospital is performing almost the majority of the fertility preservation consultation, but also vitrification of oocytes, and the private sector is also participating to this activity, as you see in this graph. We have made a survey through the African Federation of Fertility Society to have a picture of what's happening for the pediatric oncofertility in Africa. And 12 African countries participated. Pediatric oncofertility is, as Maria, you have shown, is more difficult. It requires more resources, and without surprise, we have seen that the offer for pediatric oncofertility is not spread in Africa. For example, for the ovarian tissue, we have only 2 countries at the moment of the study that reported performing ovarian tissue cryopreservation, which is unfortunately the only option for pre-pubertal girls. And not having ovarian tissue cryopreservation in the continent is a lot of missed opportunities for all these young girls and women in the African continent. But surprisingly, when we look to the map of the countries reporting having a specialized pediatric cancer hospital, and when we match it with the map of the African countries reporting having an RT center, we see a lot of cross-matching of similarities between those countries. And if we look to these 2 maps, we may ask ourselves why we cannot connect those facilities together to have more than 2 countries offering ovarian tissue cryopreservation. So the current situation is like RT and the freezing are spread in the countries and well mastered, and there's some successful experience in Africa already. At least 4 to 5 countries are doing well and having a real program of oncofertility. So the ground is suitable to spread to other countries who are already ready. We started the collaboration as I'm going to present, and unfortunately, the pediatric oncofertility requiring more resources is still limited in the continent. So what are the barriers? The barriers are universal, but they are even more important in Africa. In my opinion, the financial barriers are not the most important one. I think because I have traveled a lot in different African countries to speak about oncofertility, I think that networking doctors is the biggest issue. There is a lack of awareness among oncologists who are suffering from the lack of resources. They are feeling fertility preservation as a luxury, as something which is not a priority. And also there is a difficulty to connect all these people together and make them communicate to build together a program of oncofertility. But all the countries that succeeded to build a real program, they all have done the same solution. I mean, we need some persons, some champions who are going to knock on the door of each team of oncology to personalize the friendship with the referent, to be reachable, to say, to explain that it's a standard, that it's safe, and that it's possible to do it in our country, and then to build a relationship of confidence between the oncologist and the fertility specialist. And this is how we succeed now 10 years ago or less, 8 years ago in Tunisia. We were facing a lot of difficulties to convince all the oncologists with the oncofertility and the fertility preservation. At that time, it wasn't really included, or it was recently included in the guidelines. But after that, and after 2 years of going to each team one by one, now the program is robust, and it's, I think, a chance for the patient. So the medical skills may be also a problem in the continent, because you have to master the cryopreservation, especially for the ovarian tissue, for example, for the oocytes. And the clinician have to also have all the knowledge for the ovarian stimulation, which is quite different from the other situations. So to gain knowledge now, it's not difficult, because we have such all these possibilities, like what we are doing now, the webinars, the online opportunities, the conference, and also the South-to-South collaboration, because all this successful experience in the continent may spread to the neighbors through collaboration, like we are already doing. The Federation of Fertility Society is also organizing webinars and surveys to raise awareness about the importance of fertility preservation. And during the last year, there have been a lot of events in Africa about fertility preservation and oncofertility. I had the chance to participate to some of them, the other not, but you see, from Cameroon to Uganda to Egypt to Morocco, Algeria, and in September in Nigeria also, we had a scientific event about the oncofertility. So as you see, there is a awareness now about the importance of such activity to be included. And I think the next step will be to build the bridge between the fertility expert and the oncologist in a different part of the continent. So we have to support the existing oncofertility program in Africa, and to help them to become those who will spread their knowledge to the neighbors, to start some programs in countries who are ready for that. For sure, there is financial barriers. In Tunisia, for example, we are still fighting to cover the drugs. The drugs and the gonadotropins are already covered by the national insurance for the infertile couple, but we are still fighting to have this coverage for the fertility preservation. In Morocco, the situation is going on the good way, as well as in South Africa. The cost, maybe it's less expensive than other parts of the world, but it's still very costly for the local population. The champions maybe are in Egypt, but those amounts are very expensive for people who are facing the cancer and who are paying out of pocket for their treatment of cancer. And that's why having this kind of health offer in the public is very important. In this recent study published 1 month ago, we see that even in Africa, there is some countries with public IVF centers. And in most of those centers, there is a coverage of the large part of the cost with a small co-payment from the patient. So it's important, I think, to focus in Africa in the public centers, those who can provide affordable oncofertility to the patient. There is some other idea to help, like the philanthropic the national funds to include the oncofertility in cancer plans, and to also ask the pharma for access programs for the oncofertility patient, and also pooling or mutuating the resources. For example, for the ovarian tissue, we may have one center providing the ovarian tissue cryopreservation and different surgery room that may get the ovarian tissue and then send them to one center to have less expenses. Of course, Maria, you speak about the social and legal barriers. It's very heterogeneous in Africa, because it's like in Latin America. We have some people who are some countries, mainly Muslim, who are not now willing to change the legal aspect about the third party as sperm donation or egg donation. But there is a lot of other countries in Africa with no legal barriers, and they may offer this kind of possibilities to their patient. So overcoming the cultural barrier, we have faced that when we started our experience. For example, we have been in media, we have been speaking in TV to explain directly to the patient, but also we have changed some of our medical procedure. For example, for the oocyte pickup, you know that we may have some very young patient, and the parent or the patient themselves are not accepting transvaginal procedure. So we have used this old technique for oocyte pickup, which is going through the bladder, to avoid the transvaginal procedure and to make the patient or their parent comfortable with the idea of fertility preservation, and to increase the access rate for our patient. And we have published this technique 5 years ago. So the condition for implementing a fertility preservation program is the same in the whole world, but it's more difficult in Africa. Because yes, we need the laboratory equipment, the expertise in cryopreservation, the multidisciplinary and the network approach, the changing the patient pathway and make it financially accessible and sustainable for the patient. But what I'm believing that first of all, we need some champions, we need pioneers who will advocate and will find funds and fund the equipment for their laboratory, and they will build the network locally with the oncologist. And this is how it happened in different parts of Africa. And the different success stories started with some persons who believed in oncofertility and have done a lot to make it possible. And I have to acknowledge again all those persons, especially the hospital where I have been working. We had a lot of collaboration with the doctors, but also the nurses, the midwives. All the persons were there to make it possible with few resources. So the take-home message is that oncofertility is a hope for our patient with cancer wishing to become parents, and it's our duty as a healthcare provider to advocate and to work hard to offer this hope for our patient. So the barriers are real, but impossible is nothing if we have the voluntary, if we are working together to overcome the barriers. So we have to engage, and in my opinion, I think that in every part of Africa where we have already both assisted reproductive techniques and oncology treatment, we should link the bridge between them to offer this hope for our patient. So I have to thank you for your attention, and thank you for the Oncofertility Consortium for the opportunity to share what is happening in Africa. And thank you for all the champions who were working hard in Africa to make it possible. and I'll be happy to answer to your questions.
Thanks a lot, Mohamed, for your great talk, and thanks a lot also, Maria, for your great talk. So now we can open the questions. So if please feel free to raise your hand and turn on your mic and camera to ask questions directly to speakers if you have questions.
Are we allowed ourselves to ask questions?
Yes, of course. But you will answer, yeah.
Not to myself,
Maria.
but to Maria. I have said that in my introduction that I really enjoyed your talk, and I have some question about the reverse Twitter study you made. It's nice to see what is going on in the social media, but I have seen that in Africa there is not a lot of people speaking about fertility preservation, but maybe it depends of the language. I'm not sure because you have seen, they have showed that South Africa and Egypt are maybe the most country speaking about the oncofertility, but maybe because they are English speaking. No.
That's definitely a bias of the study. You know, the terms mostly used are English terms. And although you can adjust, you know, your search to try to find a translation that's appropriate for several languages, for example, Spanish, French, or whatever, there's still a bias in which most of the tweets are in English, and it's hard to search fertility preservation for all languages. So when we first published this study, I was talking to Dr. Salama maybe to do a search with several languages, with different people from the Oncofertility Consortium, because there's not only the African concern, but also the Asian concern regarding Chinese, Japanese, which might be a totally different language. So we were doing some efforts in trying to do a new Oncofertility Twitter-based search, but having more languages to see whether that impacts, you know, the engagement we can have. We also know that technology has arrived late to the African countries. They have less internet access or rapid internet. So it's also true they're less engaged than high-income countries in having their smartphones and social media. So of course, there's a bias, and I think we can improve the search, and you're more than welcome to work on it to include the African languages. But I think that's something we wanted to do through the Oncofertility Consortium in order to have the translation, because it's not only finding the tweet, but also explaining what the tweet is about. So we might need, you know, some expert in French, or, you know, Arabian or Japanese, Chinese. So that's something we're trying to construct on for future research plans.
Yeah, you'd be surprised that the African people are very well connected, and they love the social media, but not to Twitter. Twitter is not very popular in Africa. Other social media are popular, and we'll be happy to help. I have here my friend from Ghana, Adam, who is connected, and Dr. Khrouf from Tunisia also are with us in the, and we'll be happy to conduct this kind of study. That's a very nice study, very nice idea.
Any questions from the audience? So I have a question until we receive. Yeah, Gina?
Yeah, I had a
yes, please.
I had a question for Maria. I'm from St. Louis, Missouri, in the middle of the United States, and wanted to see if I heard you correctly. Are you using the GnRH agonist as a form of fertility preservation, or is it just for period control during?
Yeah, it's for both. We're using it, you know, to fertility preservation, period control, and also to help those patients that don't want to do fertility preservation, but want to preserve hormone, you know, production over the following years, you know, try to prevent early menopause to appear after cancer treatment. So we're using both indications.
Okay, thank you.
Thanks a lot, Gina. So I have a question for you, Mohammed, and also for Maria, regarding what is the best model to implement in a country, because, for example, regarding oncofertility practice, of course. For example, in many developed countries, they have the national cryobank and the national centers of excellence in oncofertility practice. Maybe one big national cryobank or few regional cryobanks. These cryobanks in the country, 1 or 2 or 3 cryobanks, they act as a very big hub to build experience, to build competency in all aspects in oncofertility. And of course, they receive patients from all over around the country, because the number of oncofertility patients are not too many. So if there is a small IVF center, this small IVF center will not receive too many cases per year, and that's why it will not be helpful to build competency. So having a very big institution or a national cryobank in a country will help a lot to build this core competency of practice in this country, will help to have accurate registry, to train doctors, to also be able to fund the oncofertility programs, to buy these advanced machines, to do training for especially the cryopreservation of gonadal tissue, ovarian or testicular tissue. So what do you think about the idea of national cryobank and national center of excellence in a developing country like Tunisia or Mexico?
It's definitely worthwhile. We have a National Institute of Perinatology, which takes care mainly of all those women public hospitals trying to do cryopreservation. Funding has been limited, and as all expenses are supposed to be paid by the patient, unless there's research funding or funding from the government to give patients that opportunity, they haven't had a huge experience. And sometimes, the patients will get private medicine counseling just because our private facilities are less overwhelmed than our public facilities. So unfortunately, the experience is mixed. Some of them have been on the public setting, but most of them have been on the private setting on different small clinics. And that has precluded the fact that we can get all the information together, just because patients might go to different small IV private centers that may have, faster opportunities for cryopreservation or easier ways to pay for that expense.
Thank you, Mahmoud, for your idea. I mean, this is what I was speaking about when I said that for ovarian tissue, for example, it's important to decrease the cost and to have the expertise. So having one center or one cryobank to cryopreserve the ovarian tissue, knowing that in different parts of Africa, there is a lot of surgery theta with laparoscopy. I mean, we have a lot of people who are getting the ovarian tissue, and we have to have one protocol to send the ovarian tissue to one center to have less cost. But in the other part, you have also to consider the specificities of the African countries. Some countries like Algeria, Nigeria, Egypt also are very big and very, very big. And imagine what is going to happen with patients who want to, for example, to have their egg freezed for breast cancer, having all this trip with some transportation who are not very effective. I mean, it's not a patient-centered orientation. It will be, I think, important to start, because we have to start in some situation. We have to start, But if we continue the experience, we have to also to have some satellite especially in the biggest country. For example, in Tunisia, we have 2 or 3 centers now freezing eggs, but our colleagues are calling us for the ovarian stimulation to have some advice. They are ruling on the ovarian stimulation, and then they send the patient only for the oocyte pickup, and the patient come back home. This will decrease the cost because the patient will stay 1 or 2 days in Tunis and not spending a lot of money for the venue, for the hotel, and so on. And this is how we can find the solution for this patient. We didn't develop yet the protocol for the ovarian tissue, because at least for the ovarian tissue, it's 1 day. So the patient come to the hospital, for example, Aziza Othmana, which is public. They spend the night and they have their surgery, and then they come back to their oncologist. But I think we have to adapt the policy according to each country. Maria said that Latin America is heterogeneous. Africa is also very different. We have some quite rich countries, less rich country. We have some big countries, but the idea to start with a center of excellence of expertise is good. To have to also to think about the patient. Are we going to help patient to access to fertility or not?
Very good, very good. Thanks a lot, Mohamed and Maria, on this. So we have a question from Gina to you, Maria. So she's asking.
Yeah, sorry, I typed it so I wouldn't forget.
Okay.
Yeah, we're grasping at straws here in the U.S. to have some kind of research guiding us with Lupron, the GnRH agonist. Wanted to see if Latin America has anything that we could glean from that maybe we haven't researched here.
I really don't think so. We've also maybe, experience from Europe and other areas of the world. And I think we have some registries mainly from Argentina. I can share with you if Dr. Salama gives me your records. Mainly it's retrospective evidence of what we've done, but really nothing new in terms of the use of it, rather than starting it early before chemo and trying to prevent ovarian failure related to chemotherapy. And that's especially what we've done in terms of medical oncology. And regarding costs for countries, there's really a very heterogeneous healthcare system. So when we usually ask for GnRH analogs for fertility preservation during chemotherapy, there are Arthur routes nowadays, so we don't have that cost problem in the public practice setting. It might be a little bit difficult to justify that on the private practice setting, because they might sense that it is for fertility preservation purposes, but not for treatment. And they might decline it, because they do not cover fertility. But in the public setting, since we have GnRH analogous authorized as actually as a treatment for women with breast cancer, we don't have that problem because it's in our list of medications we can use. So usually we see a patient with breast cancer and we treat her with, for example, surgery and then chemotherapy, and then we want to give hormonal therapy because she's hormone positive breast cancer. We usually used to give tamoxifen for those women, which is an estrogen receptor antagonist or receptor modulator. But we know that there's studies with GnRH analogs and then aromatase inhibitors for young women that have provided more suppression of the ovarian cycles, and that's known to be an adjuvant treatment, and that's authorized for breast cancer all over Mexico. So that's why, since it has become a standard of care treatment, we can actually use that indication, though it's not precisely for that. That's why we're using the GnRH analog, but we can get this very easily authorized, and we can protect a woman by giving it during chemotherapy. So we don't have that problem as we did before, because it's on our list of basic treatments that women have access to.
Thank you. Very nice.
Thank you. So I have just a question, maybe before, we almost 1 hour now. So for you, Maria and Mohammed, so your slides showed that the developing countries are lacking ovarian and testicular tissue cryopreservation. Of course, there are places doing this in the country, but still there is need to support this practice. So what do you recommend to enhance the training and also the practice of ovarian and testicular tissue cryopreservation, especially, of course, for pediatric population in your country? What do you recommend to enhance and support training and practice?
So for children mainly?
Yeah,
so for children, we have different teams, mainly the one that has worked most of the time on fertility preservation for children is the National Institute of Pediatrics. They have kind of a multidisciplinary care approach in which there's psychologists, clinicians, scientists that are working mainly on the biology field to get this tissue and ovarian and testicular tissue freezing. So it has been more a multidisciplinary approach. They try to do it upfront and navigate the patients to get their basic counseling, but that's only for our National Institute of Pediatrics, and that's only one institution among all pediatric hospitals. Most general pediatric hospitals do not get access to this counseling, just because they feel that there's no sense to give counseling if they don't have an opportunity to give an assisted reproductive technique. So still, there are efforts, but they're very, very few, and still just on third level facilities that I have researched and that have, the best specialists in the world, in this country. So I think there's a lot of disparity. Most children won't get fertility preservation counseling. Most of them will not have access to an assisted reproductive technique, and it's still an ongoing effort.
I think the most important barrier is actually medical. Both. Let's say that the fertility specialists are very comfortable with ovarian stimulation and oocyte pickup. They have done this for many years for their fertile patient, but they are quite afraid by having the ovarian tissue, especially with pediatric patient, because they are not comfortable with the surgery of the young patient. And also the biologists, they have been working a lot on their eggs, on their embryos, on the sperm for their routine infertility treatment activity, but they have never seen how to cryopreserve the ovarian tissue. So one of the solution maybe is, like I have seen in the Oncofertility conference, there is a workshop for ovarian and testicular tissue processing and cryopreservation hands-on in US, but maybe going to US is not easy for the local biologists here in Africa. So if we can organize, for example, something in the continent, and to invite the key persons from Africa, because the biologists, there is not a huge number of biologists, we can invite them and find how to find the funds to have this kind of workshop. And the workshop will interest both clinicians and biologists, just to show them that it's easy to get an ovarian tissue. Is not a big deal finally, they are making more complicated surgery in their day-to-day work, so it's quite easy to have this kind of activity. I mean, I think it's more about it's something new. They haven't learned it. We don't have a lot of pediatric cases, so if we can help with training, it will help to start the activity in some countries who are already ready for that. I mean, some countries are far away from this, but some countries are already ready to implement the ovarian tissue. We just need this final touch to make it possible.
Okay, thanks a lot, Mohamed and Maria, for your great talks and contribution. And thanks a lot, everybody, for joining us today. The webinar has been recorded and will be uploaded afterwards to our Oncofertility Consortium YouTube channel. Let me take this chance to remind you that our 15th annual conference of the Oncofertility Consortium will be hosted again by McGee Women's Research Institute and Foundation on November 6th to 8th this year in Pittsburgh in the United States. And we already launched our official website for the conference. I posted it in the chat. So we are looking very much forward to seeing you at the conference. And please feel free to contact us if you have any questions regarding the conference or our other future activities. So thank you again all so much. Have a great day and see you soon in our next webinars. Thank you, everybody.
Bye.
Bye-bye.